Yeah, I can start. So this is a paper from Diabetes Care. It's actually quite an old paper, but similar papers printed more recently, published more recently, have similar outcomes and conclusions as well. So I thought I'd go back to something more original from
How old is it?
2014. Okay, so I thought before I go into the paper, just talk a bit more about sort of glucokinase MODY. So it's maturity onset diabetes of the young. So the GCK gene plays an important role in recognizing how high the glucose is in the body. It acts as a glucose sensor for the pancreas. If there's a mutation in the gene, it sort of resets the glucose parameters, and higher levels are recognized as normal levels. And typically patients with these mutations have a fasting glucose between 5.5 and 8. So a lot higher than what we would usually see in a patient with any glycemic impairment. Patients tend to be asymptomatic, don't require treatment unless they are pregnant, and we'll go on to that. And complications are quite rare, hence why treatment is not really required. This is entirely about GCK, so it's not referring to any other types of MODY.
Okay, thank you, Margaret.
So then I thought, let's just recap on how we diagnose GDM, and based on the current NICE guidelines, but there's other guidelines that are used as well. So the risk factors recognized for women requiring testing is a BMI above 30, previous macrosomic baby, so weighing more than 4.5 kilos, previous gestational diabetes and previous pregnancies, family history of diabetes, so first degree relative with diabetes, or from an ethnic background with higher prevalence of diabetes. If a woman has had GDM previously, they recommend early self-monitoring of glucose, and they should have a 2-hour oral glucose tolerance test as soon as after booking. And if that is normal, a further one at 24 to 28 weeks. Whereas if you meet any of the other risk factors, then you just get an oral glucose tolerance test at 24 to 28 weeks. The diagnosis is made at a fasting plasma glucose of 5.6 and above. So you can already see that, if someone has GCK and we're saying their fasting glucose is 5.5 to 8, and we are diagnosing GDM as sort of 5.6 and above, the GCK women already fall in that category. So the misdiagnosis can occur in that sense. And for GDM, you need an increment of glucose on the oral glucose tolerance test, and at 2 hours, you expect it to be above 7.8 for a diagnosis. So you can meet either or criteria. I just thought I'd put this table in to look at the comparison of defining GDM, and over years, things have become a bit more stricter, I guess. NICE still says more than 5.6 of fasting glucose, but the WHO criteria is more than 5.1. Against a 2-hour increment is mentioned as well. So going to the paper, the objectives of it is to identify GCK MODY in pregnancy and why it might be important, and using a population-based cohort, because this hasn't been done before, to allow them to determine the prevalence of GCK cases and thus estimate how many women are being misdiagnosed as GDM instead of GCK. And what they did, they used clinical details from case subjects, ones that they had and ones that they combined from UK as well, in pregnancy, to estimate any clinical characteristics that can be used to distinguish one from the other. Previous studies have been available, but they use very small numbers, and here they've used large numbers, and I'll go on to explain exactly what it was. And often when they've previously looked at this, people have been assessed retrospectively. So they go back and check post-pregnancy what their glucose are, which kind of negates the possibility of influencing management within pregnancy. So this was done more prospectively. So why is it important to identify GCK pregnancy and not misdiagnose it as GDM? So the management is different. And in contrast to GDM, the birth weight of the offspring of the mothers with GCK is related to whether the fetus inherits the mutation or not. So if the mother has the mutation, there's 50% chance of passing it on to the fetus. Now, if the baby gets the mutation, it recognizes the high fasting glucose as normal glucose. So then if you were to treat these babies, they would then have a lower birth weight. Whereas if the baby does not inherit the mutation, it will recognize the mother's hyperglycemia as a true hyperglycemia. And therefore they behave as babies with sort of GDM mothers behave. So they gain weight during pregnancy, And therefore, if you don't treat these women, their babies are high risk of macrosomia and then having shoulder dystocia as this, in terms of labor and the complications there exist. So if the baby inherits the mutation, it's recommended that the mother should not receive treatment, as this will result in a normal birth weight. So I guess you're finding out whether the mum has it or not, and then treatment is based on whether the baby gets a mutation or not.
I had to ask, what would happen if you took someone who did not have a mutation as a child, but treated the mother? What is the bad outcome that will happen there?
So if you treat the mother and the baby doesn't have the mutation, you're basically, so if the baby doesn't have the mutation, then it's going to react to the mother's hyperglycemia and it will gain weight.
Yeah, so doesn't that mean we've got to treat all comers?
But what they're saying is if the baby has the mutation and it recognizes the fasting glucose as normal glucose, and that's normal for them, they won't gain the weight. And what we're doing is actually hindering them gaining whatever their normal weight would be.
Oh, I see.
They
So
actually end up with a lower birth weight.
Okay, so it's definitely a bad thing, is it? Because I'm trying to just have a look in my head. If we treat everyone, the ones that are harmed are the ones who should not be treated. But are they really harmed is my question. I don't know.
Yeah, I think what they're trying to say is there's been different studies say if we treated the babies that do not have the mutation, they have had a lower birth weight, and this has been correlated with the mums having insulin or metformin as a treatment.
Thank you.
And I think there's been a recent study in Portugal that's actually proven that as part of their cohort, and they looked at around 18,000 women in that one. I'll actually mention it later on. So the wider implication for having the maternal diagnosis, so the mother does not have an increased risk of type 2 diabetes if they have GCK, it has a normal general population risk, and it does not need treatment outside of pregnancy, and you're not at any higher risk of having microvascular complications. Also, if the mother is proven to be positive, that gives us an opportunity to test the rest of the family as it's an autosomal dominant condition. So looking at the research design and methods, so in the Atlantic diabetes in pregnancy cohort, they had 5,500 women. And what they did is they divided them into these groups of fasting glucose. So one group was less than 5.1. The middle group was fasting glucose of 5.1 to 5.5, and the other one was more than 5.5. One's less than 5.1 was the largest group. And then they looked at how many of them actually had any DNA sample available for them to run the test for GCK. Now, out of the ones that were less than 5.1, they only selected randomly sort of 10% of that group because they wanted to prove that they truly do not have the mutation, which is true. They found 0 cases out of 109. Out of the ones that are sort of in the middle, 5.1 to 5.5, they only had 129 of them with DNA samples. They tested all of them and found 1 case. Now, the women with more fasting glucose of more than 5.5, they had about 118 with DNA samples available. They tested all of them and found 3 cases. So out of their cohort, they only found 4 cases, but to make this study a bit more stronger, because you don't want to just compare 4 against 447 gestational diabetes, they got 40 additional women from the Exeter NHS Trust who had GCK and MODY and combined them to give a number of 44. So then they had 44 women with GCK MODY in pregnancy to compare those with normal glycemia and those with GDM. And they found a population prevalence of about 0.1. So firstly, what they did is divide the women into 3 groups. You've got the GCK MODY, which is 44, GDM 447, and the rest were normal glucose tolerance in pregnancy. They looked at characteristics such as age, BMI at sort of booking, fasting glucose, and the 2-hour glucose and oral glucose tolerance test. Now, if we just briefly compare, women with the GCK MODY were slightly younger. Their BMI was a lot lower than the GDM women and the one with normal glucose. The women with GCK had a higher fasting glucose compared to the other women. What's interesting is NICE says fasting glucose of 5.6 should be considered as GDM, but clearly the average here is 5.2. So maybe if we just did fasting glucose for GDM, we would miss them, and hence why we do a proper 2-hour oral glucose tolerance test. You can see from average increments in the oral glucose tolerance test, there's not much of an increment in GCK, but there is a good increment on the glucose tolerance test in GDM. Now, what they did further is had box and whisker plots for clinical variability in sort of diabetes type, and each sort of box represents normal glucose, gestational diabetes, and glucokinase MODY. The first one in A, we're looking at fasting glucose. So you can see sort of diagrammatically that the GCK one had significantly higher fasting glucose, and there's a significant difference compared to that of GDM as well. And the same thing for BMI. BMI in the GCK group was a lot less compared to, the one in the normal glucose and GDM. I guess we associate GDM with sort of metabolic syndrome and insulin resistance. So this kind of makes sense. In terms of age, there's not much difference between the three groups. And again, in terms of glucose increment, there is some difference, but probably not of significance either. So the two to sort of look out from here are your fasting glucose and your BMI as clinical characteristics. So what they did further was look at these curves, which are your receiving sort of operating characteristic curves, which look at sort of the paired sensitivity and specificity. And it said that the point of the curve that is closest to the left-hand side corner shows the most amount of significance, whereas the one that gets closer to the midline is probably of least significance. And any number above 0.8 is of greater significance as well. So you can see that A is our fasting glucose and B is our BMI. So once again, they show more of a significance instead of sensitivity and specificity of using those characteristics to differentiate rather than age at pregnancy. So doing all of this, they then came up with 3 criteria and then figured out what the sensitivity and specificity would be of each of these criteria. And if they use those criteria, how many of those 44 women they would pick up. So the first criteria was a BMI of less than the same as 21 and a fasting glucose of more than the same as 5.5. This gave them a sensitivity of about 20% and a specificity of 100. So whoever they test would come back positive, but they wouldn't be testing a lot of women because of the BMI cutoff. And therefore they would only figure out 1/5 of the cases. So 9 out of 44 would be found if they use criteria 1. If they use criteria 2, it's a BMI of less than 25 as a cutoff and a fasting glucose of more than the same as 5.5. The sensitivity increases to 68%. Its specificity drops very slightly to 99. The number needed to treat in this criteria would be 2.7. And if you use this criteria, you would determine 30 cases out of 44. So you're still missing out some, but you're gaining sort of more cases compared to criteria 1. And the third criteria is higher inclusion, so a BMI less than 30 and a fasting glucose of more than and the same as 5.5. Sensitivity again increases, specificity drops very slightly. The number needed to sort of test would be 6.5 here. So you'd be testing a lot more women, and obviously it would be more expensive, but you would determine 3/4 of the cases, so you would get 36 out of 44. And it still sort of shows you're not fully getting all 44, so some characteristics are still missed out, and I guess not everyone fits the norm there. But I think in the end they said pragmatically it'll be good to go for the middle choice in terms of costs versus other benefits. So the conclusion was that they proved that 1 in 1,000 of this primarily Caucasian population identified clinical criteria that can be used to determine which women with GDM should be tested in pregnancy. They said that this was the first study, which is a population-based sample to estimate the prevalence of GCK. And the prevalence is similar to that estimated in previous older papers as well. They said the UK National Molecular Genetics Service for MODY, only 630 people with GDM have been diagnosed to date, which is a prevalence of 1 in 100,000, which means about 99% we haven't even diagnosed yet. This was quite old. I guess things have moved on now and we're a bit more vigilant about things. Half of these missing cases will be women, and many of whom will be diagnosed with and potentially mistreated as GDM. So they're saying it's important to diagnose GCK MODY in pregnancy to optimize the management for the mother and baby. And this is probably the most important time to be done for women, because this is when it probably needs treatment rather than otherwise. So the cutoff values for fasting glucose and BMI used in practice will be influenced by the cost, as we said, and the benefits to the patient and finding the mutation, hence why they went for the middle ground criteria rather than the first and second. Strengths and weaknesses of the study. So the number of cases found of GCK was small, and there is an error around finding these as well. But they say it's the only population-based study done till date then, and by far one of the largest ones. And actually comparing, even if we look back now, it's probably one of the biggest ones as well, that's done prospectively. Although majority of the cases, even though they call it a population-based study, majority of the case of GCK were given from one of the UK trusts, so it's not, apparent to them. And the criteria are not established for a specific population or ethnic group. The majority of women in this study were Caucasian, and only 77% were of other ethnic origin. So these criteria are more specific to Caucasian population. And in calculating the population prevalence, they assume that the cohort studies is representative, but these can be error prone as well. The other thing was all based on, a fasted oral glucose tolerance or a fasted glucose measurement, but then you have to entrust your patient to say, have they truly been fasted or not? There was a similar recent study, which I sort of mentioned earlier, which was done in Portugal, which again mentions about misdiagnosis of GDM, whereas it could have been GCK. And this was a bigger study done more recently. And they looked at approximately 18,000 women with GDM and thought that about 3.6% of their population met the GCK sort of clinical criteria. And their prevalence is a bit higher than what was stated in the paper that we just discussed. But in Europe, I think Portugal probably has one of the highest rates of MODY and GCK MODY specifically. And what they concluded is higher odds of neonates being below the 25th centile in terms of weight was probably due to excessive insulin treatment cases where both the mother and fetus have the mutation. So this goes back, Prof, to what you're saying, why can't we just treat all of them? I guess this is a paper to say they found that those children that were treated and did not have the mutation actually had quite a low birth weight. And what they're saying is essential to consider the diagnosis of GCK in all women with GDM criteria for better management of diabetes. But I guess it all comes down to costs of testing. So then I thought I'd just have a quick look at what NHS England is saying about sort of rare inherited diabetes and sort of disease eligibility. So they're saying this is outside of pregnancy. If a patient fasting glucose to be raised and they're less than 35 years, and they're asymptomatic and stable with that high fasting hyperglycemia, or they have a HbA1c within this range, then these are patients that we should consider testing. In pregnancy, what NHS England is saying, if there's gestational diabetes with fasting glucose between 5.5 and 8, and a BMI less than 30 if a Caucasian, or a BMI less than 27 if high prevalence of type 2 in that ethnic group, then these should be tested. Features that support it, so persisting fasting glucose post-pregnancy, or previous babies with normal birth weight despite maternal hyperglycemia. And if we were to send off a test, then the cost is about £650. But outside of NHS is obviously much higher. There is an online probability calculator that can be used in sort of clinic settings as well. So the take-home message is, if you're an antenatal clinic and if you have a patient who meets these criteria, then we should consider sending genetics off, especially if the BMI is low and high fasting glucose, then this should be considered. I actually did an audit on this retrospectively at Chelsea, and we looked at around 240 GDM patients, and approximately 6% of those met this criteria retrospectively and could have been tested as well. Treat GDM in pregnancy only if the fetal weight is increasing, because it could then otherwise impact on the birth weight. And the X's team obviously are leading in all of this and have a really good website and are always free to sort of give advice on what the appropriateness for referral should be. And I also found that it's actually a virtual masterclass on MODY going on the 13th of June, and it's free to sign up to. And I think Dr. Misra and the authors of this paper will be presenting and lecturing on it as well.
Kaenat, can I just ask a question? Can you hear me all right? Thank you.
Yeah.
It's just about the birth weight issue that Kareem's mentioned as well. It's interesting that they talk about the birth weight being lower if babies do have the mutation. But to my mind, less than the 25th centile is still counted as normal. So do they actually have intrauterine growth restriction or measure less than the 10th centile and have associated complications?
So the paper I mentioned in Portugal, they've only mentioned sort of the odds of below the 25th.
Right.
So I don't have proper data to say how many of them are on the 10th or any lower from that. So one thing I could definitely look at, but I don't have any data to share with you on that.
Thank you. Because I guess going forwards is the implication that if women meet these criteria, then they need to be tested and their baby needs to have, they need to have extraction, don't they, to check for the fetal DNA as well, right?
Yeah.
And I guess my other comment is just a little bit about the baseline characteristics of this cohort, because when you look at our GDM, I don't know how it was at Chelsea and Westminster, but when you look at the BMI for women who have gestational diabetes in our trust cohort, our BMI is actually 27 for those women. And I suspect we're lower than that 31 because of our very high proportion of South Asian and Arab women within that group. Yeah. So I guess I'm not sure how much those criteria then apply to our cohort as well.
Yeah, so that's the thing. I think this was all mainly based on a Caucasian population, and it probably doesn't truly represent what we see in our clinics because there's so much more diversity. So I guess it'll be maybe not to follow what they're saying strictly, but maybe come up with our own criteria or whatever matches our population.
Absolutely. Thank you, Kaenat. That was fantastic. Thank you.
Can I answer Rochan's questions at Shivani? Rochan, I think you've raised a completely valid point about the definition of a low birth weight, because all of the previous studies have shown that when you look at fetal birth weight in women with GCK who have and haven't been treated with insulin, it's the same. So this study, the one that came out in DOM last year, caused a bit of controversy around that because it doesn't quite recapitulate the previous findings. And I wonder whether it's around the definition that you've just outlined.
In terms of what defines a low birth weight.
Exactly.
Yeah, absolutely.
Because as you know, you and I have looked after quite a few of these, and it's just impossible to shift the blood sugars, right? I mean, we give them CGM, we put them on tons of insulin, but we're effectively not shifting glucose. And that's because, just to labor the point, these individuals have a different set point for their hypoglycemia. So as soon as you lower the blood sugar below the set point, they mount a counter-regulatory response to boost it up again. So they end up on hundreds of units of insulin with very little benefit.
Thank you, Shivani. That's really helpful. Thank you.
Isn't that only half the children will benefit? Is that right? Have I got that right? Only half the children their mother should have a treatment.
Yeah, I think one thing they did quote that the babies that do not inherit the mutation, I think previous papers have shown that those babies have an average sort of increase of 700 grams higher birth weight, but they do not quantify otherwise on, if we were to treat them, how much detrimental loss we're having in birth weight. But I guess that's difficult to quantify as well.
I think it's also difficult to extract a bit too much just looking at birth weight because it's so wrought with complications. And I think we're getting better now at adjusting fetal birth weight for the maternal characteristics, much better than we used to be anyway. But actually, I'd argue the hard outcomes are much more interesting. So incidence of shoulder dystocia, neonatal respiratory distress syndrome, all of the things that come with a baby being relatively macrosomic compared to how the baby should be, if that makes sense. I feel like birth weight's a little bit tricky unless you have associated complications to go with it. Does that make sense?
Yeah. Yeah, and I guess this is probably why they don't use birth weight as a characteristic retrospectively to go back and check things either.
And can I ask you a slightly stupid question? I might have missed it. But if you're a lady with GCK MODY, what's your probability of getting gestational diabetes, of having? Because maybe all the mutations, Shivani might be able to answer this, are different, and their set point being different. What is your probability?
Well, I'm not sure about GDM, and probably Dr. Misra or Dr. Agha is better positioned to answer this, but they're saying in terms of having type 2 diabetes, which is again an insulin resistant type picture, their risk is the same as a general population. And I guess it depends on how you diagnose it, isn't it? If we're saying they have a high fasting glucose, therefore they meet the criteria for GDM, then we would just treat as that.
It's a really interesting question. So there are hundreds of different mutations that affect the glucokinase gene, and some of them will only modestly raise the blood sugar, so that the threshold is like, I have actually seen a couple of cases with a fasting glucose below 5.5, but there are a percentage that exist between 5.5 and 6.1. And so, yes, there are some women with glucokinase mutations who don't even breach the threshold and would not be detected. It is completely random as to where those mutations are, and as to the genotype phenotype correlation as to how much it raises your blood sugar depends on how much the enzymatic function is perturbed by the mutation. And evolutionarily, I don't think there is actually in other MODY genes, but in glucokinase, there's no reason, I think, evolutionarily why the mutations that perturb the function more would be favored or less favored, for the very reason that none of them cause complications. So I think it's fairly random. And then, yes, as Kaenat said, the chances of a woman developing GDM on top of glucokinase, and it is worth saying that that does happen, and also anyone with glucokinase can develop any type of diabetes, that risk will be down to population level risk. Does that answer your question, Jeremy?
Yeah, no, that's very helpful. Yeah, that's great.
So I think we don't bother at all. What will happen? What's the bad outcome if we just forget about GCK in pregnancy and treat everyone on their merits of diabetes and glucose in the normal way? What is the problem with that? That's for Shivani.
Well, it's as Kaenat said, right? So the issue is, so it is, I take your point, Kareem, the point that you're making is that even when we try to go in and treat the blood sugars, we fail to really bring the levels down to a point where we can avoid the complications of fetal macrosomia. But, you know, having made my previous comment that I did in response to Rochan, I do also think that there is probably some merit in treating the insulin resistant component of hyperglycemia that occurs on top of the glucokinase, which is why we do put these women on metformin, and we're just trying to take the top off of those glucose levels to reduce the extent of macrosomia. And the other thing is the best practice guidelines recommend 2 weekly ultrasound scans so that we can be more proactive about detecting fetal macrosomia and, you know, move in earlier with elective deliveries. So yeah, sorry. So by the way, it's free currently. Okay, so free in inverted commas. That we no longer get charged for any of this genetic testing. The cost is covered centrally by NHS England and Genomics England. So as long as they meet those criteria that were showed up, they will get testing. In terms of what's driving, you know, should there be more, you know, ubiquitous testing? I actually don't think it's a cost issue, Kareem. So the problem is when you test people that don't have the phenotype, you identify variants of unknown significance and novel variants, which become incredibly difficult to, you know, determine whether they're actually disease causing or not. So this is a sort of, as you know, a genetic paradigm really that we should be testing. We can definitely broaden criteria and test some people who don't quite meet it, but we shouldn't be blanketly testing people who clearly don't have the condition. And there's numerous examples of where that has the potential to cause harm.